No, I don't think I need to say anything except just to reintroduce Peter and say that he is a man with a lot of expertise in the development, just not of clinical stroke services, but also the management of stroke itself and other multidisciplinary enterprises. So we're very privileged to have him here to talk to us, and thank you very much, Peter.
Thank you. Thank you very much. It's a great pleasure to be here, and it's particularly a pleasure to see David again. He was one of the bright young Australians who visited Edinburgh when I was one of the less bright young Glaswegians who visited Edinburgh. So it's great to see you again. Thank you very much for the invitation. As you see, the rather ambitious title of this presentation was going to be the future of stroke care. And what I really wanted to do was to go over some of the evidence around conventional service approaches and if you like, the rationale for having particular components for a stroke service, but then go on to talk about some of the challenges I see in the way that stroke care is developing and some of the conflicts that brings up, and maybe just finish considering some of the ways which we might be able to resolve these. It's partly a UK perspective, but I think there are probably lessons for everywhere. I should just mention my warnings and my biases. I'm based in Glasgow. I'm essentially a geriatrician at heart. I've got firm belief in multidisciplinary team care, so I've got that kind of bias. I think my approach is a bit conservative. I would emphasise with the small c, but conservative. And I do tend to take a public health type perspective, trying to, some of the information I'll provide is a kind of big picture. It's about how many extra independent people you have at the end of a process rather than specific details of the recovery. So I'll apologise if that seems a bit crude, but it was just a way of presenting it. Having said that, given my biases, I thought I'll move on, try and do a bit better than our financial services have done with their systems of care, and try and support what I'm saying with some evidence, rather than just give you my opinion. One of the things I think it's worth remembering, if you're looking at services from a population perspective, is of course that stroke disease covers a spectrum of severity and the spectrum of needs. So we need to think about services that can deliver all the different parts of that, of those needs, through from very transient symptoms with TIA right through to those with devastating stroke, and ideally how would we meet the needs of all those groups of people. And the other thing that I wanted to do, there's a little bit of a delay, I need to remember this. The other thing I wanted to do was to think about how you meet these needs in different parts of a service. So for instance, through outpatient clinics or through inpatient services in hospital, and how you manage different parts of that process, the discharge transition and continuing rehabilitation. So I'm trying to sort of include all of these components if possible. And just to summarize, there we go. I was thinking about a range of service options, and I've got them shown up here on the slide. That starting at the left-hand side is really the time of symptom onset, moving through to the right with the passage of time. And what I wanted to do was to look at the evidence around different service models at different parts in that patient journey. And I'll just go through these in sequence and try and put them into context in terms of the impact that they might have on patient recovery. And I want to start with, the rapid access TIA service. And this is probably appropriate for a small number of stroke patients and really everyone who has transient ischemic attack. And the small number of stroke patients that we would see are those who often present late, relatively minor symptoms, but present late and don't want to go into hospital. And this is a group that the needs are essentially to do with secondary prevention. And David will recognise the person in this. It's a very young Professor Sanderco. And this rapid access type service is really aimed at providing rapid diagnosis, investigation and secondary prevention to people who've got resolving or resolved symptoms. And the rationale for this is quite good. We've got probably 3 standard groups of therapies: the antiplatelet drugs like aspirin, the anti-cholesterol things like statins, and the blood pressure therapies that are all very clearly effective at preventing recurrent stroke. And then there's a smaller group of people, those, for instance, with atrial fibrillation who need anticoagulation, and a small group, I would emphasize it's a small group, who need early carotid artery surgery because they've got severe carotid artery disease. Now, I'm not aware of any randomized trials in this area, but what there is one study from Oxfordshire, which is called, it was called the Express study. And I'll just explain, this was a group in Oxfordshire who were doing a community-based study of stroke and TIA in the whole district. And what they did was they identified everyone with stroke and TIA in that district. And they looked at the natural history of the disease. And at the time they started, they had a conventional service for these patients. And the purple line on the graph shows the pattern of drug prescribing during the conventional phase of that study. So for instance, people got onto a statin drug, but it took a little while. Similarly, not so many got on to clopidogrel, one of the new aspirin type drugs. And generally they were a bit slow in getting people onto blood pressure lowering treatment. And if you put the dotted line that's about to come up, there we go, that's the 1 week point. 1 week after somebody had their symptoms, you could see that in the conventional service they were really slow at getting people onto these medications. But what they did after 2 years was they put in a whole new clinic, which was basically a daily service, and that people could be seen, rapidly assessed, and started on appropriate medication. And they were given tablets in their hand to take, before they left the clinic. And what you can see is what it did was it delivered the desired treatment actually within less than a week. So it just qualitatively it wasn't very different, but it just speeded everything up. And the other thing that they did was, sorry, this develops rather slowly. They did speed up the surgery for those people who needed carotid artery surgery. This is just a picture of a diseased carotid artery, which is a source of embolism in a small group of people. And although they speeded that up as well, the biggest impact was in the simple drug prescribing that I showed a moment ago. And what they did in this study was, say, they tried to capture everyone in the whole district who had a minor stroke or TIA, and they just plotted what happened to them after they developed their TIA or minor stroke. And one of the surprises from this study was that about 10% of these people would go on and have a recurrent stroke quite quickly, within 3 months. So what they were observing was that this was a group of people at high risk of recurrent illness. And in a proportion of these people, the second stroke was a bad one, was disabling. Not all of them, but in a proportion. And so what they did was they observed this for 2 years, and then they carried on the study, but they brought in their new clinic system. And I think the result surprised everyone, in that with their new accelerated system, they almost abolished recurrent strokes. And these results mirrored what was seen in some other parts of Europe, where they have a very active approach to managing these people, where the rate of recurrence seemed to be much lower than in the UK. And what they found was that for every 100 people who were referred to their clinic, they were preventing 8 strokes, and 2 of those would have been disabling. So there were 2 extra independent survivors as a result of having this speeded up system. So that was the first part of, if you like, the service summary that I would like to mention. The second one is the stroke unit, and I presume some of you, maybe all of you, work in the stroke unit, so you won't need so much convincing about this, but stroke unit care is appropriate for the great majority of stroke patients. I've said 80% there. We have some who don't come into hospital. We have some who become ill in the renal unit or in the surgical unit, and they have other sort of pressing care needs. So you don't always get everybody. But certainly the great majority would be eligible for stroke unit care. And the evidence base for this is, I think, is quite impressive now. There are stroke unit trials, clinical trials from every continent except the Antarctic. And I'm not really holding my breath for that one. There's a trial, a small study, but done many years ago in Perth, and there are a lot from Northern Europe and Scandinavia. And all of these trials have really tested, they were all different in some way, but they all tested conceptually the same approach, which was, what is the impact of having a dedicated area in a hospital where stroke patients are looked after by a multidisciplinary team who talk to each other